Quick disclaimer before you listen. The World's Okayest Medic podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols. It is about to be my favorite time of year. Fall is upon us. I can bust out the flannel shirt. I can wear jeans, hoodie season. If you're at work, it's job shirt season. The girls are in leggings and Ugg boots. They're going and getting pumpkin spice drinks. My buddy Clancy also likes pumpkin spice. It's something I will never really be able to get behind. Not my jam, but this is my favorite time of the year. So why not celebrate fall's arrival or impending arrival and talk about some intubation things? Because airway is everybody's favorite topic, I think. One of my favorite topics. And I had 3 separate listeners reach out to me with scenarios that they encountered at work. One was at their paramedic school internship, and these were patients that indeed had some type of legitimate clinical etiology, and they had altered mental status, blah, blah, blah. And these people, workers, students, whatever, asked if I thought that those patients should be intubated. Usually I do podcast topics when I get like 3 or more of the same question in a short period of time. That's an indication that I should dedicate a podcast episode to this topic. Please keep in mind as I opine and soliloquize that I am not your medical director. I am not your paramedic school instructor. I am not your preceptor. I wasn't there. I didn't lay eyes on those patients. So, who requires intubation in the pre-hospital environment? And my opinion is that it's not a hard criteria thing. GCS less than 8 is fucking stupid. As I have said many times before, there were plenty of times when I, a college student at the University of Delaware, was so obtunded from a hard night of partying that a paramedic who had an RSI box and a laryngoscope could have justified intubating me just based on the GCS less than 8 thing. And I did just fine sleeping it off in my bed. For me, you have to consider the totality of the circumstances when deciding to take or not take somebody's airway. You have probably heard me say that totality of the circumstances thing a million times at this point, and rightfully so. No patient and no situation is the same. That's why it's hard to apply hard criteria to intubation. I have had patients with profoundly decreased mental statuses that I have made the decision to intubate, and I have had similar patients who I've made the decision to sit them up, monitor them closely, provide some supplemental oxygen, and ride them to the hospital. I'm not saying that I was right to have managed those patients in a particular way, and I'm also not saying that I was wrong. Usually, though, it is not a black and white thing. One crew may approach a patient and decide to intubate them, and another crew may approach that very same patient and decide to manage their airway more conservatively. And both crews can be right. From years of experience, and this includes not just watching people work or reviewing what other people have done, it certainly, probably more so than anything else here, includes my own evolution in clinical decision-making. And that involves maturity, some hard lessons learned, and just overall career development and continuing education. So these are my insights. I think the first question that you must ask, and I doubt you're going to hear this on another podcast, is, are you going to take this patient's airway because they truly need it? Or is it something that you just want to do and you can clinically justify it? Let us be totally honest. How many patients have we put down and intubated, and we have made the decision on the way to the call that we're going to intubate that patient? I think that is something that we need to be very introspective about. Are we intubating the patient because they need it right now, or they will continue to seriously deteriorate without it? Or do we just want to do the skill and we can justify doing it? I intubate far less people than I used to. Yeah, the patient that I have that I don't intubate damn well may need to be intubated. at some point. But you must ask, is right now on the scene or in the ambulance or in the helicopter, in our austere pre-hospital environment, the right place to do it? And it might be. I'm not saying that it's not. I think that the emphasis needs to be on an overall resuscitation mindset, other than this bullshit that we have been taught in paramedic school for years, that airway is basically a zero-sum game, that either the patient has an airway or they don't. And if they don't, they will die. So we must secure it. And I think that that is oversimplifying things to the point of abject stupidity. We need to shift from a gotta establish an airway mindset to an overall resuscitation mindset. And a threatened airway does not mean a lost airway. So we need to be very honest with our self-appraisal. Do I like doing procedures as much as the next guy? Yeah, I actually love intubating patients. Do I want to be one of those medics, though, who has a reputation of putting down and tubing anyone who twitches and blinks at the same time? No. And I will repeat my quote that I put on another podcast and on social media that another content creator blatantly stole and repurposed as his own, and then said, when I called him out on it, that he had read it in a book, and then I got the book and was not able to find the quote in the book. Let's move past it. But my quote was that a wise and methodical provider is better than a hopped up skills jockey any day of the week. I have mentioned before that I know a couple of medics in particular who are actually quite good at intubation. They have a great first pass success rate. I've watched them intubate. Their technique is excellent. But passing a tube aside, they're incompetent paramedics. They are a weapon of mass destruction. Idiots, one-trick ponies. Yeah, they can get a tube in anyone. And yes, skill performance is critically important, but airway management is just as much, arguably probably more so, about good clinical decision-making than simply the skill performance. We must tube the patient for the right reasons. So let's get to brass tacks. Who am I putting down and tubing in the pre-hospital environment? Again, this is much easier said than done because you need to lay eyes on the patient and consider the totality of the circumstances. I no longer intubate people because, well, the textbook says that this patient should be intubated, or we're going to get QA'd if we don't secure this patient's airway based on the assessment findings, or I'm going to get shit if I roll into the hospital and this patient isn't intubated. Fuck all of that. I do what is right for the patient based upon my clinical judgment. If I can conservatively manage a patient who has altered mental status or breathing that is suboptimal with less drastic measures than putting a pipe between their vocal cords, then I'm going to do that. And if the receiving hospital wants to bitch about it, then that is fine. They will invariably find something to bitch about anyway. I am not intubating someone unless there is a goal that I am trying to achieve. What is that goal? Well, it depends on the patient and it depends on the situation. So let's talk about some specific scenarios. I don't know, general specific. I don't know. Let's talk about some scenarios. Airway burns, they get intubated, plain and simple. After the burn, like when they come out of the structure, they may often look very well and they may have no complaint and they may be breathing perfectly adequately with no stridor, no hoarse voice, but they will precipitously get worse and they will have an incredible amount of airway swelling. So we must tube them early, even if they look okay. Now, I know there is some literature out there that says that a lot of patients with suspected airway burns get inappropriately intubated. I read the stuff that someone sent me on this, and I must be honest that I found it extremely unconvincing. And I will go as far to say that patients with suspected airway burns that I encounter, they are the only patient population where you will hear me say, oh, well, if they end up not needing the tube, then they can extubate them at the hospital. Because this population is truly a group that may completely lose their airway and suffocate to death by the time you get to the hospital if you don't do it early. And good luck criking these patients, saying, oh, I'll just crike them if they need it. You get this taut, distended, swollen neck, and you slice it and you just get more swelling tissue. Good luck. A very good medic that I know learned that lesson the very, very hard way. And if it could happen to him, it could happen to me, and it could happen to any of us. So tube those patients and tube them early. That being said, be smart about it. Do a good assessment. The presence of facial burns and singed hair does not always mean that the patient has airway burns. I have had many patients with pretty bad burns to the face from grills and flash fire cooking mishaps. And those patients typically don't have airway burns because it was a momentary flash of fire in their face. I am talking about intubating the suspected airway burn of a patient who was in a structure fire and they were breathing in superheated gas, singed nasal hairs, and carbon on the tongue and carbon in the nose are boom, right there, trigger pulls for me to intubate the patient. I had one lady with minor external burns from a motor vehicle accident. She was briefly trapped in the car. The car caught fire. She had some minor burns, but she looked all right. And she had a little bit of blackness on her tongue. And we decided to RSI her. And as we were pushing the meds, I was thinking, this is completely overkill for this patient. And when I put the video laryngoscope in her airway, I think I gasped out loud by how bad her airway burns were. It was a real learning lesson for me. So tube those patients, tube them early. Thank God we pushed those RSI meds and tubed her when we did. So that's what I have to say about airway burns. I tube them and I tube them early. But that's a minor percentage of the patients that may need airway management that we encounter. So sometimes with some patients, it's an airway protection issue that I cannot effectively manage any other way. There's endless potential scenarios for this. The first and most recent patient that comes to mind was a guy who fell down the steps. He presented to us with unequal pupils. He was posturing, and he had vomited a great deal while lying on his back before his family found him. He had aspirated. He was hypoxic. So this guy had a demonstrated inability to protect his airway, and it had caused negative consequences for him because he had already aspirated. That's not somebody who's going to get better. Conservative management was not going to work on this guy, and this was not somebody that I could just prop up and give them a little supplemental oxygen, and he bought a tube. I actually find that, especially doing flight neurotrauma like that, accounts for the vast majority of intubations that I perform. Much less frequently, but sometimes I have to intubate a respiratory failure patient. Now, this is much more common in the hospital, and it should be. It should not be that common in the pre-hospital environment, in my opinion, especially now that we have non-invasive ventilation. I say that like it's a new thing. We've had non-invasive ventilation for like 25 years. But sometimes I do have to put down and intubate a respiratory failure patient in the back of the ambulance. Although I am very wary to intubate those patients because while they may seem like relatively simple intubations, and they often are skill-wise, there's often nothing to them as far as passing the tube. They are very complicated because they often do not respond well to the knocking out of their sympathetic response with induction meds. Like you take a septic patient with a really bad pneumonia, you can and you will knock out their compensation and they might crash. Same with cardiogenic shock, bad juju. If they are in status asthmaticus, a rapid sequence intubation followed by the induction of positive pressure ventilation into a chest that is already hyperinflated, that can put huge amounts of pressure on the heart and great vessels and cause a catastrophic drop in preload and cardiac output. And that RSI will have the same physiologic effect on the patient as if you put a 45 to their head and pulled the trigger. Listen to Haney Malamat's Status Asthmaticus lecture. Status Asthmaticus is terrifying, and you absolutely should avoid intubating those patients if you can. Treat them aggressively with meds, non-invasive ventilation if you need to, but seriously, you might kill them if you intubate them, especially with RSI. DSI, probably a better option. Not going to go too deep into the weeds with DSI into this podcast. DSI is one of those things that I was initially kind of like a naysayer to pre-hospitally, but I have come around. I believe in it now. And this would be a good indication for DSI, but even still, we want to avoid tubing the status asthmaticus patient in the pre-hospital environment. Even In the most optimal intubating conditions in the hospital, with all of the tools and backup in the world, it's still unbelievably dicey to intubate those patients. But sometimes the patient is going to fail your oxygenation and ventilation interventions, despite aggressive treatment regimens and despite the wonderful tool that we have, non-invasive ventilation. I am not of the belief, as far as non-invasive ventilation, I am not of the belief that you can't put someone with altered mental status on BiPAP or CPAP. I would argue that is antiquated thinking. Probably something you'd hear from an Orange County, California medical director. It is not like we are putting it on at the hospital and we have 5 different patients to tend to and we can't keep a close eye on them. We are sitting next to that patient in the ambulance. And if they puke or they stop breathing optimally, we can pull that mask right off of them and intervene. But sometimes non-invasive therapy, as great as it is, doesn't work on the patient. Those patients most likely need to be intubated. While I do use non-invasive ventilation on patients with altered mental status, and I will argue that it is okay until I'm blue in the face, no pun intended, if I put somebody on BiPAP or CPAP and they are unresponsive and they head bob a couple of times and they have a respiratory rate of 5, then that's not going to work. And you need to take control of their respirations with a BVM or a ventilator. And if I'm going to have to bag valve mask someone for more than a few minutes, I'm probably intubating them. Bag valve mask ventilation is great and all, but it's not a good long-term strategy. After a while, you will insufflate the abdomen despite the best technique in the world. When you insufflate the abdomen, it puts pressure on the lungs, makes them difficult to ventilate after a while, also makes them highly prone to aspiration because all that air in the stomach will just push out those stomach contents. So if I am bagging a patient and they don't improve after a couple of minutes, they don't start breathing on their own, or some other treatment that I'm rendered while I or another provider is bagging them, I'm probably pulling the trigger and I'm going to tube them. Dare I say that I do, especially in these situations where I'm bagging the patient, I do consider proximity to the hospital. I know that there is all this stuff on social media about proximity to the hospital is not a treatment, nor is it a justification for not treating someone. Yeah, it is. Sometimes, not all times, but sometimes, yes. Years ago, when I worked in the urban environment, I was working in the hood and I had a pedestrian get waffled by a car, quite literally just down the street from the hospital, which was a trauma center. And this guy was jacked up. He had deep altered mental status. He was posturing, if I recall. He had this neurogenic breathing that wasn't really adequate. Lots of injuries. He had facial trauma. And I was bag valve masking him. And I was just going to roll the 3 blocks to the hospital. You could literally see it down the street until the supervisor, Medic 100, if you know, you know, showed up and insisted that we sit on scene and perform a sedation-assisted intubation, which we did. And it was fucking stupid. I was pissed about it then. I'm still pissed off about it today. Granted, today, I would have been much more aggressive when I spoke up to argue that we don't do it and we just go to the hospital. But I do consider proximity to the hospital. Now, let's say I have that patient and it's a 40-minute transport to the hospital. Well, bagging that guy isn't going to be an optimal strategy. As long as his hemodynamics could tolerate it, or if they were soft or he had a high shock index, we would resuscitate him appropriately. Once we resuscitate that patient, that is a guy I would probably intubate. Now, you may not find this in a textbook or in a protocol set, but sometimes I'm intubating somebody because they're in a completely uncontrollable state. I want to be emphatic and I want everybody to listen. I am not saying that we should use intubation as a measure to control a combative patient. Absolutely not. We have protocols for that. We have ketamine, we have benzodiazepines, antipsychotics. What I am saying is that some patients just cannot be effectively managed or safely transported in the state that they are in, and we need to take total control of them. I will say, though, and I was just talking to Dr. Bert Schiffer, who was the medical director who came on the podcast in May. My kids got to listen to a very enthralling conversation about the benefits of ketamine for avoiding intubation. after I picked them up and was driving them home from school yesterday. So the conversation was, now that I have, and well, at least at my flight service, the ability to give a sedation dose of ketamine, 1.5 milligrams per kilogram, and repeat it liberally, we don't have to intubate nearly as many patients as we used to. And he said the same thing about his service and his practice as a physician. I'm sure that Bert is going to come back onto the podcast sometime and we can talk about all of that. But ketamine has revolutionized them. But yes, sometimes I do have to intubate somebody just because they are super duper seriously injured and because they are super duper seriously unmanageable. And straight up, we need to take total control of that situation and slow everything down so everybody can think appropriately. I did an episode a while back about a multi-system trauma patient that I had on my flight team. You open the doors of the ambulance and you immediately get hit in the face with the stench of a drunk person. The patient was absolutely out of control, screaming wildly. She had facial trauma. She had a deformed leg. She was wildly combative. 4 people were holding her down. They had already given her fentanyl for her pain, tried to climb off the stretcher. She's kicking her broken leg. Was it the alcohol? Was it the pain? Did she have a closed head injury? Probably all of the above. But my partner and I looked at each other and we were like, this is like pissing into a hurricane. We've got to knock her down and take control so that we can manage her. That was the goal. She was oxygenating fine. She was protecting her airway on her own-ish. But there was no other way to manage her otherwise. The pain meds they gave her prior to our arrival had done nothing to help her. It was like going on a call and the patient has the TV turned up to volume 20,000. There's 3 dogs barking at you and chomping at the bit to rip you to shreds. And once someone goes, can you put the damn dogs away, and you turn the loud TV off, everyone can finally think and be like, okay, now that we are back to sanity, what is going on here and what are we going to do? And it was kind of that situation. How do you put that into criteria in a protocol? Like, she had altered mental status. She had facial trauma. She's kicking her broken leg. She's trying to climb off the stretcher, but her GCS was like a 9.25. So we really can't intubate her because GCS less than 8. Like, you can't put that kind of shit into a criteria. This is why I believe that if you're going to give paramedics the ability to intubate, give them all the tools that they need, not like the horseshit Pennsylvania sedation-only intubation protocol. Either give us the tools to do the job right, or just tell us we can't do the skill. But I digress. I think that paramedic protocols, if they are going to allow intubation, here are the tools. Use them. Use clinical judgment. Don't try to restrict it so much that you paint the paramedics into a corner. But I digress. And again, this is another lesson in considering the totality of the circumstances. And there is a very, very, very fine line when you do this, because I am not saying to knock down and tube combative patients and patients who are seemingly unmanageable right off the bat. But I will say that we have facilitation of safe transport as an indication for intubation in our protocols for a reason. I think I made things there clear as mud. So real quick, coming close to the end here, let's wrap this up. Who don't I intubate? Rather, I should say, who do I try to avoid intubating like the plague? I'm going to go through it real quickly. One are patients with an increased shock index. They need to be resuscitated. Resuscitation before intubation does not mean resuscitate before you intubate. Yes, you may end up being the one to eventually do that too. But I say that we can provide very meaningful resuscitation to patients on the way to the hospital where they can then be intubated. Status asthmaticus, you already heard me talk about that. To review real quick, you'll kill them. Listen to Haney's lecture. When do you intubate them? When should you intubate them? Nobody knows. There's literally no good answer. Another population I don't intubate are patients with GCS less than 8 who are breathing adequately on their own, and there is no immediate indication that they are going to aspirate. Put them in a Fowler's position and let Mother Nature manage their. And generally, I no longer intubate based on anticipated clinical course. That has long been used as criteria to pull the trigger and intubate anyone in the pre-hospital environment that the paramedics wanted to intubate. And I'm talking about pre-hospital environment. I mean, anticipated clinical course certainly is a real and good indication for intubating somebody, but let Dan and Haney in the hospital make the decision to intubate based on, hey, this patient isn't getting any better. They're headed in the intubation, mechanical ventilation direction. So let's just do it now. That is often very appropriate, but sorry, friends, we aren't physicians. We're not advanced care providers. Let us just focus on intubating the patients who really need it in the austere pre-hospital setting, because Lord knows there is a shitload that can go sideways, and the procedure is not without consequences, even when executed perfectly. I don't know if I answered any questions there, but that is what I've got. Thank you for listening to me ramble about this favorite topic of mine. With that, go out there, be fruitful, manage airways, take care.